Hey, welcome back to Not So Complicated, and today we'll try to uncover uncomplicate ulcerative colitis, one of the most vulnerable and volatile topic that we seem to forget even after multiple revisions, but not after this lecture, right? So let's begin without further delay. So ulcerative colitis is an immune-mediated inflammatory bowel disease targeting the colon's mucosal layer, and this is the colon, and it shows pseudopolyps, right? So that is what like gross findings of the ulcerative colitis would look like. So the causes of ulcerative colitis or risk factors of ulcerative colitis in genetic factors is HLA-DR2. So HLA locus has a like vulnerable part of the gene in ulcerative colitis, and in also family history there is increase of 10 to 20% of incidence, and in identical twins there is high concurrence. Up to 50% of the cases are related with identical twins in this ulcerative colitis. And environmental factors are dysbiosis, that is altered gut microbiota, and then triggers like NSAIDs or stress can also lead to ulcerative colitis in long term. And then in infections like clostridium difficile can cause acute flare up reaction, and there are some protective factors against ulcerative colitis like appendectomy. In patient who has already gone appendectomy, there is decreased risk of ulcerative colitis. And in smoking, like if you are a smoker, there is a decreased risk of ulcerative colitis. That sounds weird and vague, right? But if you are a smoker, then there is increased chance of Crohn's disease, which is also inflammatory bowel disease. So better not smoke. So in distribution of ulcerative colitis, there are three types. So one of them is proctitis, that is like exclusively in the rectum region. So that is proctitis in 30 to 50% cases, and left-sided colitis, you can see left descending colon kind of thing. And then another one, the most severe one, is extensive colitis or pancolitis, up to 20% of the cases, right? So talking about pathophysiology, so it leads to like the development of this disease is due to abnormal interaction between host immune cells and commensal bacteria, right? And there are two different things that happen. One is dysregulation of intestinal epithelium, and another is dysregulation of the immune system. So let's talk about intestinal epithelium first. So there is dysregulation of intestinal layer that will lead to an increase in permeability for luminal bacteria, right? So and that bacteria will be presented to the macrophages and dendritic cells like by antigen presenting cells, right? So antigen presentation happen, and then that will lead to four different events. The first one is secretion of pro-inflammatory cytokines like interleukin 6, 12 and TNF alpha, and chemokines like CXCL1, CXCL3 and 8, right? So these are the pro-inflammatory cytokines and chemokines that will lead to the inflammation. So the other factor that happens is recruitment of other immune cells like neutrophils to the site, and then differentiation of naive CD4 plus cells to TS2 T helper 2 effector cells will occur, and that will also lead to the play the key role in development of the inflammation, right? So another one is recruitment of natural killer cells, right? So these are four events that happen due to dysregulation of intestinal epithelium. And there is another thing, that is dysregulation of the immune system. Talking about that, what will happen is that there will be an upregulation of lymphatic cell activity in the bowel walls, like in the site of inflammation, that is like in the site of insult. Due to dysregulation of the intestinal epithelium, there will be upregulation of the lymphatic cell activity like T cells, B cells and plasma cells, like, and that will lead to an enhanced immune reaction and cytotoxic effect on colonic epithelium, and that will lead to inflammation with local tissue damage like ulcerations or erosions or necrosis, right? So this will lead to autoantibodies like PANCA against cells of intestinal epithelium and TS2 cell mediated response. So this is the image right here. You can see all these dysregulation of the immune system, and then intestinal epithelium is wrapped up in here. You can pause the video and see and try to decode this pattern, because you have to do the active recall, not only the passive informations right here, right? So that is how you remember. Talking about the clinical features of ulcerative colitis, there can be intestinal feature or extra-intestinal feature. And in intestinal features, there will be body diarrhea with mucus. This is the most common presenting feature. And fecal urgency, abdominal pain and cramps. Tenesmus. Tenesmus is actually the incomplete voiding, the feeling of incomplete voiding of the stomach. Like you have just passed the feces, but you still feel like you have to pass the feces, right? So that is tenesmus. And constitutional symptoms are non-specific symptoms like fever and weight loss. These are non-specific symptoms that doesn't happen in ulcerative colitis, but that occurs in Crohn's disease, right? So in extra-intestinal manifestations, you can see here conjunctivitis, iritis, episcleritis. These are the extra-intestinal manifestations in eyes or ocular regions, and mouth ulcers, fatty liver, liver abscess, mesenteric or portal vein thrombosis, venous thrombosis, large joint arthritis, erythema nodosum, and pyoderma gangrenosum. These two, pyoderma gangrenosum and erythema nodosum, these are very important because these are much commonly presenting symptoms is in extra-intestinal manifestation. And unrelated to inflammatory bowel disease activity, some of these lesions are autoimmune hepatitis and the PSC, that is primary sclerosing cholangitis, and cholangiocarcinoma. This has a very much common association with ulcerative colitis, right? You have to remember this primary sclerosing cholangitis and ulcerative colitis together. So talking about the diagnosis of the disease, you can see this this figure. This is an endoscopic figure, and you can see the ulcerations there, semi-confluent ulcerations, right? So erythematous and edematous mucosa indicating active inflammation, a loss of superficial vascular markings obviously, and several linear semi-confluent ulcerations. You can see the green overlay of that ulcers right there. And this is the abdominal X-ray finding actually, and then this is in AP view. So there is loss of ostration. You can see the green overlay here too. So there is loss of ostration of descending colon, and that will lead to the lead pipe appearance. So lead pipe appearance is a classic feature of ulcerative colitis. You cannot forget that. The other one here is thumb printing of the abdominal X-ray, grossly dilated colon due to severe UC, that is ulcerative colitis, marked mucosal edema, and thumb printing, right? So last but not least is the treatment of ulcerative colitis. There is a step-up approach for this. So mild disease to severe disease. There is this pyramid that we have to follow. But before that, you have to what do you have to do is to exclude an infection. So if this is the symptoms are due to an infection, you have to exclude that, and then only ulcerative colitis treatment strategy should be followed. So 5 ASA compounds like sulfasalazine can be used, mesalazine can be used, and if that doesn't relieve the symptoms, you have to use or go up to the steroids like corticosteroids. The most common is budesonide, and then if that doesn't even work, then you have to go for immunomodulators like azathioprine and 6-mercaptopurine or methotrexate, right? And if that doesn't work, then you have to go for biologic agents like anti-TNF antibodies, right? So infliximab, rituximab, and that are the biological agents that we have to follow. And also there are anti-P450 antibodies, P40 antibodies, right? So if all of this doesn't work out, then you have to do the surgery, that is colectomy, right? The most commonly done surgery in ulcerative colitis is partial colectomy, right? So partial colectomy with end state ileostomy. So that is the most common surgery done in ulcerative colitis. So the surgical treatment of ulcerative colitis is definitive treatment. So you have to follow that. So that is all about today, and I hope you learned a lot of from this video. And please subscribe for more clinical polls, and thank you for staying with me.